Of 9:45, so we are going to begin our work for the day. And if I could please ask you to rise for the Pledge of Allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Good. And I'm going to open the hearing on Senate Bill 60 or House Bill 63 relative to the use of nasal spray to treat anaphylaxis. And prime sponsor, Representative Erica Leon. Welcome.
Thank you, Mr. Chairman, and it's great to see you in this body and in that seat. This House Bill 63 is actually a very simple bill to deal with a new approval. Last year, a nasal spray of epinephrine was approved. So it's like the EpiPens, but it uses the exact same delivery system as Narcan. This bill, almost every single page on here is simply existing the updating statutes for camps and schools to allow the nasal spray to be used in the same places that the auto injectors are used. There is another additional section which was flagged by the pharmacist because there was some confusion around the orders for the schools. That's on the very, very back page. On section 8, it says it adds a pharmacist may dispense epinephrine auto injectors and epinephrine nasal spray pursuant to a prescription issued in the name of a school, post-secondary institution, or independent school. A school under the direction of the school nurse may maintain a supply for use in accordance. Basically, that is cleaning up some language because after a bill was passed last session to allow schools to have epinephrine auto injectors on hand, there were some pharmacists who were not sure that they could actually fill a prescription for a school because that wasn't in the statutes. So we have that section added in on behalf of the pharmacist to make it absolutely clear. I do want to say that there are two bills on epinephrine that were introduced in the House. This is a very, very simple, clear one that just gives parity for the new technological development of the nasal spray throughout all the statutes. It's written to take effect upon passage so that camps will have them in time for summer camp because these do a lot better in hot vehicles than the pens. So this one hopefully is an easy bill that you guys can get signed by the governor so schools and camps can start using these. The other bill is House Bill 677, which is currently in House Finance. That one is around more of the epinephrine in schools. All I ask is that when that comes through, we'll make sure that the language stays consistent between them because it touches some of these same statutes. But I just ask that you update our law to reflect medical innovation. And if you have any questions, I'm happy to take them.
Any questions? I had a quick question. So it actually goes back to the last thing you said, keeping up with innovation.
Mm-hmm.
Would you be opposed to a friendly amendment that rather than call out the specific dosage form or delivery system, i.e. auto injector or nasal spray, we just put epinephrine? As I'm aware of a couple of other dosage forms that may be coming to market imminently, a sublingual or a film tab. So to save you from coming back here next year to do the same thing, is that something that you would be agreeable to?
I would. And I think that's actually a great improvement because there may be some schools where they want to have a single-use vial because they have a nurse on hand who is well-trained and is able to use a $1 vial instead of something that may cost hundreds of dollars. So given your background, I trust whatever language you have. And if you can also have input when the other bill comes through as well to make sure that it reflects those same updates, I'd be very, very appreciative.
Great. Thank you very much. I'll let you get back to your busy day.
Thank you very much.
Thank you. Jonathan Ballard. Good morning.
Good morning, Mr. Chairman and committee members. My name is Jonathan Ballard. I work as the Chief Medical Officer for the New Hampshire Department of Health and Human Services. I come before you today to provide information about this bill and about nasal spray epinephrine and auto injectors. So there are indications for the use of nasal spray formulation of epinephrine, particularly among needle phobic or children who are scared of needles. Typically, when we're having an anaphylactic reaction, it is a life or death situation, and the medication does need to be administered promptly. So this is a approved medication. It is covered under the Medicaid program. I will inform you, though, that it does have a rather strict prior authorization process. The cost of a auto injector currently is $45 to the Medicaid program. The nasal spray is $710 per dose. Therefore, we do have a strict prior authorization process and restrict it to only children who have a intense phobia to needles because it is a life or death situation in that setting. So it is allowable, but very restricted. I do appreciate your comment about getting away from talking about the route of delivery system, as there are other drugs in the pipeline that could come along, as you mentioned, so that could remove the need in future years of having come back and visit this part of legislation. Thank you.
Great, thank you. Are there any
Any
questions for Dr. Ballard? Senator Bertzel.
Thank you, Dr. Ballard, and thank you, Chair. This bill doesn't require the nasal spray. It just, if they want to. So if the school knows that they have one or two children that are susceptible to needles, they can opt into this, correct?
That is correct. And from other than the very last part of this bill, it's still the child's medication. It's a prescription for the child that them or their parents are filling and being placed at the camp or school. So it's the child's medication. I have heard, and this relates to the other bill that Representative Leon was mentioning, some interest in allowing those filled medications in an emergency to be used for another child. I mean, that's in an emergency situation. And that could save schools considerable amount of money because they wouldn't necessarily have to purchase the medication themselves to have on file. If there is a child who already has the medication at the school nurse's office or under controlled by, I think, the principal or the camp director, then it could be. But currently, the standard is that you don't give another child a medication that's not theirs. But in the course of an emergency, I could see how that would be a different standard. So that might be some way to save the school district's money.
So the medication, whether it's nasal or whether it's injection, would be the parents of the child, so they would be
It would be,
burdened with the cost of it.
that is correct. It would be
Okay.
parental choice, and it would be
Okay.
typically the insurer of the child for, you know, 60,000 children in New Hampshire. So it'd be the state with the state Medicaid program.
Thank you.
Senator Ibarra, did you have a question?
Just as far as the strict prior authorization, do parents know that they qualify for that stricter definition, and will the schools know as well?
Senator Avard, that's a great question. So when the medical provider, it prescribes the medication, if they were to prescribe only the nasal formulation and the parent were to go to try to fill it at the pharmacy, it would be placed on a hold, requiring a document called a prior authorization form to be sent to the provider to say, why are you using this formulation when it's $710 versus $45?
Right.
And then the pharmacist would receive approval back from the insurer after the completion of that process.
Thank you, Doctor.
Any further questions? Anyone else like to comment on House Bill 63? And I'm going to close the hearing. Oh, that's all right.
Oh, really?
Yeah, it is. I'll allow it. No high drama today.
Oh, I don't know.
Not here, not here.
By the way, when the mic's on.
No. Good morning. Welcome back. It's 10 o'clock. We're going to open the hearing on House Bill 72, extending the commission to study telehealth services. And do we have, I don't see Representative Edwards. I'll have Senator Avard introduce that bill. Actually, yes, please do.
Thank you, committee members. For the record, I'm Senator Kevin Avard, filling in for Representative Jess Edwards, and he owes me a favor. House Bill 72. This bill basically directs the commission to study telehealth services to submit supplemental report by June 30, 2026, and provides for repeal of the commission on that date. And I appreciate you listening to my long speech.
Thank you. Thank you for your work on this. Holly Stevens.
Good morning, Chairman, members of the committee. Thank you for the opportunity to testify this morning. My name is Holly Stevens. I'm the Director of Public Policy at NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a nonprofit grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. And on behalf of NAMI New Hampshire, I'm here today to speak in support of House Bill 72 to extend the Commission on Telehealth Services. The Commission to Study Telehealth Services began meeting in 2020 pursuant to House Bill 1623 of the same year. I have served as the representative from a nonprofit social services organization representing the patient perspective since the inception of that committee. First as an employee of New Futures and then transferring over as an employee of NAMI New Hampshire. Several times the commission was presented with claims data, and all this data is available in their report if you have any desire to look at it, regarding the telehealth visits that have happened in our state. The data shows that mental health psychotherapists and substance use counselors provide approximately half of their client services in the form of telehealth services. And the data also shows that 80 to 90% of all telehealth visits in our state are behavioral health visits. So this is extremely important to the mental health services that happen in and around our state, especially in the North Country and the west side of the state where they have a shortage, there's a shortage of providers all over the state, but it's even more severe in the North Country and in the western part of the state. In the recommendations, the commission found that telehealth continues to be a valuable tool for delivery of healthcare services, particularly for mental health services. But it also found that for physical health services, particularly for acute illnesses, it was very valuable to help get the process started for treatment. And I myself, actually, when I had COVID, called my doctor's office and I said, I did a home test, I've got COVID. They didn't have me come into the office. They did a telehealth visit with me, went over the symptoms, and then prescribed Paxlovid immediately. So it's helping in, the spread of disease as well in that way. The commission recognized that the adoption of effective use of telehealth is still an evolving process. And as a result, it recommended that the commission be extended for another 2 years to continue the work that it's been doing all along. So for that reason, we are in support of this bill and urge the committee to vote ought to pass.
Great, thank you. Are there any questions from the committee? Seeing none, thank you very much.
Thank you.
Dr. Ballard. Welcome back.
That's super. Good morning, committee members, Mr. Chairman. My name is Jonathan Ballard. I work as the Chief Medical Officer of the New Hampshire Department of Health and Human Services. I was on the telehealth committee from its inception, representing the Department of Health and Human Services. And over the last 2 years of the lifespan of the previous committee, I served as the chair of the commission. Previously, I provided a copy of the telehealth report that Ms. Stevens has represented to you very accurately. There were a few areas that warranted continued study and areas for potential improvement in health outcomes for the state, but also improvement in cost and efficiency. As we know, the state is aging. We have an increasing population of the baby boomer generation that will be aging into needing services, including home health services. Currently, there are some inspiring new technologies that could leverage the use of telehealth to improve home health services. We had committee members from the Home Health Association to testify that it's currently being used to discern when individuals could need a extra or may not be necessarily need a home health visit from the visiting nurses associations across the state. They warranted further study in this area to see how telemedicine can be used further. There are other areas that were promising that we're seeing in other states that are completely not adopted in New Hampshire. One of those areas is called the hospital to home model. This is where the use of telehealth can actually prevent or have a patient be able to leave a hospital much earlier in the course of the illness and receive completely comparable care at home as to being in the hospital through the use of telehealth. Remote patient monitoring, giving the providers the exact same types of monitoring as if the patient is in a hospital bed, having nursing care when they need it through home health visits, use of technology to do all the exact same things as if the patient is in the hospital. This is being done in other states and paid for by Medicaid programs in other states, but is not adopted at all in New Hampshire. So there are some areas that were reported on in the last over the last year as needing further study, and for that reason, I understand that the sponsors of this bill wanted to extend the life of the Telehealth Commission.
I've got a question. Are you on the commission? Do you participate on it?
Well, the commission expired. I was on the commission. I served as chair the last 2 years. Previously, Senator Khan was the chair,
Sure.
and when his term in the Senate expired, I was elected to serve out and help assist with the final publication of the report. So this would be recreating the commission, and it's not determined who from DHHS would be the representative.
I mean, if we were to do this, I would like to expedite the recommendations out of the commission to get this moving. I mean, to hear that we're behind the, in a state that prides itself on technology and has a big industry of it in our state, I think we should be out in front on this. So I would be interested in seeing the recommendation and implementing any type of legislative recommendations they have.
Senator Rochford, with the commission would constitute under the same membership as previously, so we'd be looking for a Senate member, and typically the Senate member has served as chair.
Oh, what have I done? What have I done? What have I done? All right. There any other questions? Senator Birdsall.
Hi, thank you, Dr. Ballard. So looking at the duties of the commission, there, are there any other additions? Because number 3 says review other information and material as determined by the commission. Is there anything anything additional that would be covered that you think should be covered, would it fall under that? Or do we need to add some duties?
I think the language as is written is fine, and
Okay.
that the commission has the full authority to explore all areas of telehealth. Another area I can mention is that could improve the health of citizens and reduce the state expenses is that the use of telehealth more in the correctional setting. As you may be aware, the New Hampshire Department of Corrections has purchased and currently installing telehealth booths
Yep.
for confidential interactions between the inmates and their healthcare providers without the need for transportation, the need for extra security, and the risk involved in that setting. So this could be another area that could be further studied, for example. But I think the language as is written provides that flexibility.
Thank you.
Are there any other questions? I see Senator or Representative Edwards has walked in. We're on House Bill 72, your bill. You're welcome to speak. Otherwise, I think we may go into executive session on this bill right now.
Thank you for the opportunity to trust the.
Yeah. Thank you.
I appreciate the invitation, so unless you want some remarks, I'm going to defer to what you've already heard.
We're good.
All right, thanks.
Anyone else that would like to speak on 72? I'm going to close the hearing. Representative Nagel? We might not be able to do this.
Thank you, sir, for the promotion.
Yeah.
I don't want to speak very long. It's just that I think one of the best things that came out of COVID actually was increased access to telehealth. I have a statewide practice. My practice usually, actually, I guess I'm supposed to tell you who I am first, right?
Yes, please state your name.
Yeah, I'm David Nagel. I'm a physician and I also represent Belknap District 6. Getting back to what I was saying, I mean, this was absolutely a wonderful change to healthcare. I have patients that live all the way up on the Canadian border that used to have to travel to see me 200 miles round trip merely for a 5-minute visit, which makes absolutely no sense. This has dramatically improved my ability to care for my patients. Not long ago, we received a notification from CMS, which I know doesn't directly have much to do with us, but indirectly it does, informing us that there will be changes in policy that were very concerning to me and my ability to care for my patients. To me, that means that we have a system in flux and that we need to stay on top of all of that, and we need to be able to coordinate with federal folks to make sure that we provide the best services we can for all of our patients. And I realize that behavioral health is a common reason this is done, but I can't live without it. So thanks.
Great, thank you. I'm going to close the hearing on House Bill 72. I think he was first. I'll give you the second. I don't know. Maybe he's just louder.
That's true.
He's just louder. All right, so I'll let you do the next one. Motion from Senator Avard, second by Senator Birdsell. Do I have a motion?
Move on to pass.
I have a motion ought to pass with a second. Any further discussion? All those in favor say aye.
Aye.
Any opposed?
Consent?
We got a motion to consent. Second, all those in favor of consent?
Aye.
Aye.
Opposed?
I'll take it.
And Senator Avard is going to take it out. We have a motion to come out of executive
So moved.
session. Second. All those in favor say aye.
Aye.
Two minutes to spare. You. open the hearing on House Bill 73 relative to harm reduction, substance misuse, and the Governor's Commission on Alcohol and Drug Abuse Prevention, Treatment, and Recovery. With that, I'll ask the prime sponsor, Representative Nagel, to introduce his bill.
Thank you, Mr. Chair. I just gave you my crib notes to look through to make it a little bit easier for you. As I just said, I'm David Nagel. In addition to being a physician and a representative, I've been involved in pain care and addiction policy for the last 35 years in this state. We've been trying to strike a balance between the needs of those in pain and those with addiction for a very long time. And at some point, we will hit the sweet spot. We have not quite gotten there yet. I'm very excited to be a part of this bill that was originally brought forth by Senator Waters last year or 2 years ago. It brought together a diverse group of stakeholders, bipartisan, nonpartisan, to sit down and really talk about what's a really big problem in this state and nationally, and how we could come about improving how we handle or treat people with addiction and prevent the harms that can result from that. In this seat, in addition to being what I just said, I also chair the State Health Assessment and Implementation Program, and I'm also the vice chair of the Opioid Abatement Commission. So this bill is really important to what we do for both of those things. The way this thing started was an observation. Number one, and I'll define harm reduction in a second, but it's on page 3 of the bill in detail if you want to look through that. It's an important element of multiple programs. In the Opioid Abatement Commission, we have 19 indications in this state that we can use that opioid abatement money for. This is one of them. The Governor's Commission has actually listed harm reduction as a pillar of what it does. SAMHSA, Substance Abuse Mental Health Services Administration, also considers this part of the state of the art about how we deal with people with drug addiction and things like that. The goal of this legislation, though, was first of all to identify there was virtually nothing in statute to talk about this, and there needed to be some amount of legislative oversight of the practice. The other thing that was really important that we discovered as well is that when we're looking for grant money to pay for these programs, we really needed common terminology to be able to align what we do with what's done nationally. Otherwise, you can't even apply for a lot of these grants. And that's the concept of creating new financial support. We wanted educators to know about that, which was in the original bill. And I will leave a lot of the other discussion of the fine points of the bill to Senator Waters, who's much more eloquent about that than I. With all that said, harm reduction is defined in there, but I wanted to tell you exactly what it is, because when we started this process, we did not know what it was. And now we do. Prevention is a huge gap in the way we treat all sorts of healthcare problems, drug addiction not being the least of them. And they define prevention into 3 phases. There's a primary prevention, meaning that you prevent people from getting addicted to start with. Secondary preventions like the diversion programs we have in this state, somebody's kind of started down that road and we want to nip in the bud before they go very far. And that's why we put money into offices of restorative justice, diversion programs, and things like that. Harm reduction is a very different concept. The person's well established in their addiction. They have set themselves up as a risk for themselves and to others for serious consequences. And the concept is to minimize those risks. There's a variety of things. Everything's listed in that definition there, but for example, naloxone programs to prevent death, drug testing to make sure you know what you're taking. And just so you guys know, cannabis tainted with fentanyl will be coming to this state at some point. So if we think that the drug testing equipment's trivial, it's really not. That's already exists in other parts of the country. And on and on. There's a number of different things in there. One of the concerning elements was safe injection sites, which was controversial, and that was another thing that kind of said why we wanted to study this further. As far as this bill was concerned, last year it passed this body on a voice vote, and it came to our chamber, and I had a number of concerns about the bill. I loved the concept of it the more I learned about it, but I did have some serious concerns. The first one was harm reduction wasn't even defined. And we felt that it really needed to be defined in statute and then guardrails placed up so that we could limit at that. And we put a lot of effort. I met with folks from SAMHSA to sit down, come up with a definition. I met with Republican leaders, Democrat leaders, everybody to figure out how we could come up with a definition that we all could agree to. And that's what's in the bill right now. Secondly, we need to define what drug misuse meant. And the reason why is you've probably heard a statistic that there's 12 million cases of drug misuse every year. Everybody sitting up there has misused a drug at some point in your life. I guarantee you, if you got a prescription for codeine for a knee surgery and used it for some other purpose, you have officially misused the drug. You're part of that statistic, and that is not what we're talking about. We're talking about people that are using drugs for reasons other than a medical reason, and that needed to be defined, so we put that definition in here as well, and that was really critical to me. There were fiscal implications that were important to people. The education issue was not important because it already exists, so we did get rid of that. The other thing I felt was important was protecting the right of people that have a legitimate need for these substances to not have their access denied, which unfortunately a lot of public policy has led to that, and that's led to some serious consequences for people in need. So we put that in there as well. Let's see, we defined that. Eventually it did pass our body, as Representative then, now Senator knows. It did hit a hiccup in finance, and that led to a meeting this summer where we sat down with Senator Waters, Representative Edwards, and Patrick Tufts from the Governor's Commission, and we said, well, how can we make this bill perfect? And we did something really, really neat. So addiction is something that affects everybody. It's not just the person with the addiction, but the people that live around them and people in society as well. And the problem is, having had 2 family members die of cirrhosis in the last 2 years, I'm fully aware of the challenges that their addiction created for their own families. Harm reduction needs to include not just the person with the addiction, but also for the families as well, and also the greater society. So what we ended up doing was changing the term harm reduction to something called reduction of societal and individual harm, which is a relatively new concept. But I did talk with my folks at SAMHSA, and they said that is a really neat thing to do, and they're glad that we did it. So throughout this bill, wherever it says, it used to say harm reduction, except for in one place, that terminology has been used. So right now, where we're at is what I think, and I hope that this will accomplish, is that we're going to promote a coordinated, cooperative, interdisciplinary model of care, which is badly needed for complex medical problems. I will tell you that this same strategy of harm reduction is what's helped us with our AIDS crisis. We did the exact same strategy, exact same strategies to minimize the harm of that. So it does have a history. Also, we'll be improving the ability of us to get non-state money to pay for these things. And we've been assured by the folks at the Governor's Commission that they don't even need state money to do what they're doing. And affect lives in a more positive way. And that's all I have.
Very good. Are there any questions? Senator Long.
Thank you, Representative. First question is, you mentioned that those that are just beginning, we have a program for that. Is there a length where you say it's more of an addiction? Is it a year? Is it 6 months? Is it 2 years?
When is it officially an addiction? Is that what you're saying?
Or when is it that these programs go into effect? How
The diversion programs are generally instituted by the courts. So for example, if you, supposedly it's for any offense of any kind, you can get referred to a diversion program. You're just starting down that road of criminal behavior, but the vast majority of what they deal with is drug related. It's people that have made a mistake in life, people that, had a bad life circumstances and made some bad choices. The judge usually is the one that will institute it. And before you get too far down that road, they'll send you to these programs. And they're actually very successful in preventing recurrent criminal behavior. And so that would be considered more of a secondary prevention. That's really not what this bill's about, though. But it's really important.
Sure.
And your county does probably have one. Only one county doesn't have such a program.
Right. follow if I may?
Yeah,
Thank you.
absolutely.
Do we have data on, like, for example, in the city of Manchester, we had a serious syringe issue. And we found out that the syringe program was leaving possibly in a year's time, 100 to 90,000 needles in the city that our parks and recs were picking up and police were picking up. So is there data on like the test strips? If I'm an addict, I'm getting ready to shoot up, I test and there's X amount of fentanyl in here. Does it matter to me?
Yeah, I'm gonna probably defer that to two of the speakers after
Okay.
me, but please ask the question
Yeah.
again. Yeah.
Okay, great. Thank you.
Any other questions? Thank you very much.
Thanks.
Senator Waters. Okay, Representative Edwards.
I'm Representative Jess Edwards, District 31 in Rockingham. I have to get back to session. We're voting today. So I appreciate Senator Waters letting me go first, and he should clean up on this anyways. This is really his bill with Dr. Nagel, and I first became involved with it when it hit Division 3 last term, and a concern that kind of my contribution to this has been the introduction of the phrase that you'll see a few times in the legislation about balancing societal and individual harm. I think we may be the only state to do that balance between societal and individual harm, the only legislation that'll do that anywhere in the nation. Why was that balance important? Because we have seen some instances nationwide where the focus of just minimizing individual harm has led to sort of some extreme policy positions. For example, in Portland, when the homeless were basically tying up the downtown retail and really affecting sales and tax revenues and the like, the mayor tried to move those from loitering and was sued on based on their harm reduction law. So we wanted to make sure that in those cases where somebody's got to make this balance, that we don't put all the weight on one end of the spectrum, that there has to be a scale. And then also, I think it was driven home in the New Hampshire House here recently over a debate on sanctuary cities. It was proposed that if we were to eliminate sanctuary cities, that would be in violation of harm reduction. And so because this is a new concept and needs to be worked out and learned by new legislators and enforcers, we wanted to make sure that in all cases people understood that there was this balance, the societal balance. This bill was perceived to be important enough that Division 3 included it in HB 2. So you'll see it as an HB 2 item as well. I hope that you support it. You're going to hear all the detail from Senator Waters, who's just been great to work with on this. And I'll take questions if there are any.
Are there any questions?
All right.
No, you're free to get back to work.
Thank you.
Thank you.
Just got to press those buttons.
Yes. Senator Waters.
Good morning, colleagues. Senator David Waters, District 4, here to speak in favor of House Bill 73. And as has been noted, this has been a collaboration based on the bill that the Senate passed unanimously a couple years ago, but some crucial changes were made in the House. And I really want to thank so much Representative Edwards and Nagel and the chiefs of police and the others and officials in Manchester who got us to this place with this bill. I will very briefly say just what it does. First, it makes needed changes to the governor's commission. I'm a member of that commission, and I was there when we created a new strategic plan in the last couple of years that included as one of its 4 pillars what was called harm reduction. So that was not included in statute. We needed to do that and ended up with the terminology that Representative Edwards has described. Secondly, and this was an extremely important part of including law enforcement where appropriate. And that had been a real problem, particularly with the syringe service program. So I thought when I brought forward this bill a couple years ago that we should have a representative of the chiefs of police on the commission. And that's on page 2. And then crucially on page 8, require that there be consultation with local police departments in the municipalities where one of these programs authored by HHS for syringe service and other harm reduction programs are established. And that's an important partnership there. And I appreciate the support of the chiefs of police on that. Thirdly, on page 8, you will see that the bill puts in statute the Doorways program. I talked quite a bit with Governor Sununu about this. The Doorways program was established statewide in response to the crisis of overdose deaths. And I thought there's one example of if a program is established by executive order and proves very successful in its mission and delivery of services, that we ought to have it in statute. So that's what you'll see on page 8. I think most importantly, has been described by Representatives Nagel and Edwards, are on page 3, this new definition of reduction of societal and individual harm. And here is that important balance, in part in reference to Senator Long's question about needles, is that we recognize in this bill that, of course, we want to try to save lives and reduce the individual harm. And that's what recovery work and syringe service programs. It's not just the overdoses and the fentanyl testing, but it's also, somebody gets a heart valve problem, it's $500,000 to replace it. Or, we originally, Senator Gray and I and others got the syringe service program started because of HIV and Hep 2, So, yes, for individuals, but society, Manchester knows full well what an impact the drug misuse epidemic has had on societal harm, and it's all kinds of things. It's the downtown, it's the needles, whatever else it may be, the impacts on budgets and so forth. So I think that coming up with this definition here recognized the balance that was needed. And finally, following up on that, on pages 8 to 9, you'll see some clarifications on the existing language about syringe service programs, what kind of functions and operations they can undertake, what are the definitions of permitted activities, and again, I will mention now the new inclusion of consultation with local law enforcement on all of the things that are included there. So I really think this bill is going to do some good. I think we're going to save some lives here. And I really appreciate the support the Senate showed for this bill a couple of years ago, and I hope that we'll be able to move this forward as well. Thank you, Mr. Chairman.
Thank you very much. Are there any questions for Senator Waters? Senator Birdsall.
Thank you. Thank you, Senator, for taking my question. On page 8, line 6, where you have substance use disorder access points established, have they already been established, and is there going to be funds that need to go to them?
Those programs are established through HHS. Okay. And the funding comes from the Opioid Commission and from the Governor's Commission and from federal sources. And once the funding is authorized, then there's contractual obligations that are established by HHS. So these are closely regulated by HHS when they're being set up and authorized. But what was missing was that they also should, when they're going to set up their operation, consult with local officials. And that hadn't been done, and now it's got to be done. Okay. And I just as an aside say that I was meeting with Mayor Ruiz about this bill a few weeks ago, a great meeting. And Manchester has just been a model of good programs and how to handle the rest of the EMTs, the police, follow up with people, getting people into treatment, and so forth. And, he really appreciated what we're trying to do here because it conforms a lot of what he's doing. And also, he has just been appointed to be on this Governor's Commission as well. So we'll have the chiefs of police, we'll have the mayor. I think this really will help. So.
Thank you.
Any other questions? Senator Long.
Thank you, Mr. Chairman. So do we have, is there data on how these initiatives are lessening harm? You know, the syringe program, the drug testing, strips, the prophylactics.
Yep.
Is there data on, I mean, I know it's gonna be tough gathering that data.
Yeah, actually, thanks for the question. It's very good data collection. On the Governor's Commission, we get regular reports from HHS. They have a whole data division in these areas, and that plus the Doorways program provides data as well. If you go onto the HHS website, you'll be able to find the most recent reports that were given to the Governor's Commission just last month. Now, there are some things hard to track. You know, we are seeing a reduction of deaths. We have the data on how much naloxone is being distributed by pharmacies and so on, but we don't, you know, there's some gaps in the data that they're going to still follow up to just to see exactly which part of a program might be attributable for the reduction there. But, and then we also have, I've gone out to go to one of these service programs. Like I went to Nashua and just, you know, waited in the parking lot, and the people came by all afternoon, and the conversations with them, and they got their needle exchange card, and that these are opportunities to connect them to recovery services. But the fentanyl TEP strips, the other testing equipment, the syringe exchange, there is data on all of that. So take a look, and if there's any gaps in it, let us know, and we'll try to get some answers for you.
I will. Just one more follow-up, Mr. Chairman.
Yeah, absolutely.
Now, it was surprising to me that 50% of the users in Manchester were homeless. I thought it would be higher. So do you know if the harm reduction program is getting to those that aren't homeless?
That aren't what?
That aren't homeless?
Oh, yeah. Again, it's surprising, but not surprising, the great range of folks who are using these services. Because just in the afternoon or so, well, I've been in a couple different places, but it's people that they're working, right? Full-time employed, and sometimes in very, very good jobs, right? And there are, you know, mothers who came with their children. So these programs are helping a wide range of people. And, you know, picking up naloxone, I remember knocking on the door of a household, and a fellow who was there was actually dying of cancer, but his son was in the other room who was addicted to opioids, and he had just managed to find a way to go out and get naloxone so he could try to and equipment so he could save his son's life. So the range of people who are being served is every walk of life. It really is.
Great. Thank you.
Any further questions? Oh, thank you very much. Thanks for
Thank
coming
you.
in. Let's see, next on the list is Chief David Suckling.
Excuse me, I have a tough time fitting in these chairs. Good morning.
Morning.
Thank you for having me, Senator Rochford and members of the committee. My name is David Suckling. I'm the Chief of Police of the Alexandria Police Department, and I'm also here representing the New Hampshire Chiefs of Police Association, and we support this bill. I want to tell you a little bit about me and why I'm here and why I'm so passionate about this. In 2018, I attended an overdose that changed my life. It changed everything that I did in law enforcement. It was a Monday morning, and I got a call to a house in Alexandria. It was early in the morning too. I just signed on, and I went there, and a young man died, and he died in front of me. And as I was putting him into a bag after we completed our investigation that morning, his mum was screaming in the kitchen. Changed everything I did about harm reduction, drugs, and everything that we did in Alexandria. We spent months chasing the people that were the offenders of this, and at the same time, I felt like we had failed our community. I felt like everyone had failed this gentleman and his family. He was supposed to be at work that morning, but on Friday, he had had an argument with his with the mother of his baby, and he had turned to the only thing that he knew, and that was drugs. I vowed then and there that we would do everything that we possibly could to change Alexandria, the town of Alexandria, and stop overdoses happening in our community. We started a program, and we gave out, to this point, around 3,000 doses of Narcan in our community, and that was just to stop the dying. What I didn't realize was that we were doing harm reduction in 2018, and it was unusual for law enforcement to do this. At the same time, I needed to understand what addiction was about, and I never knew the term substance use disorder. I went to a recovery program in Nashua and learned from a bunch of guys that were in recovery what law enforcement did well, what we did terribly, and what we could do better. And I was determined that we would never have another dose in Alexandria. As part of our program to change our community, we signed on with the drug czar, Dave Mara. Thank you very much, by the way. Our town signed on as a recovery-friendly workplace, and we alone, as the town of Alexandria, became New Hampshire's first recovery-friendly community. All the company cars carry Narcan, and we give it out to anyone in the community, along with overdose response kits that carry test strips for fentanyl and xylazine. In addition, every day we talk about recovery in the police department, and last week we were successful in getting 2 people that were justice involved into recovery. We do recovery work not in spite of law enforcement, but alongside of it, and it's possible, and we're proving that we can do it. I also teach at a federal level. I was down at a conference earlier this year teaching about integrating recovery efforts into law enforcement, and I've taught several times at the federal level doing this. We're excited to be part of this commission, and we really welcome the opportunity. We're at the cold front of this epidemic, and numbers are decreasing, and I think it's little efforts like ours and other people's that are really understanding what substance use disorder is and how we can address it in our small communities, along with the state efforts that are going. The chiefs of police would like to be part of this commission, and we support this bill in its entirety, and I'd welcome any questions if you had any for me.
Are there any questions for the chief?
Thank you very much.
Just one point as well. Senator Long, I'm in a commission as well, and they talk a lot about needle exchange. And what a lot of people don't understand is that in Laconia, the needle exchange is just that. It's an exchange. They will give 20 needles for 20 needles that are received. So they're not putting more needles out into the public, into playgrounds and stuff as well. And I think that's a point that people don't understand sometimes. So I thought I'd just tell you about that. In terms of the data and stuff, I know it works, but I don't have any empirical data. I just thought I'd share that with you. Thank you very much, sir.
Thank you. Anyone else that would like to speak on House Bill 73? With that, I'm going to close the hearing. No, we're behind, so we're going to. Okay, with that, I'm going to open the hearing on House Bill 126, relative prescriptions for certain controlled drugs. I will call Representative Popovici Muller.
Thank you, Mr. Chairman and members of the committee. I appreciate the opportunity. HB 126 is a bipartisan bill written with input from both sides of the aisle. It would add Section 1, Roman numeral 4, letter D to the Controlled Drug Act to reduce the burden on patients that need to fill injectable androgen prescriptions in person due to federal scheduling by allowing them to fill 92-day prescriptions instead of 30-day prescriptions, after they file the 12 monthly prescriptions from the same medical practice. This 1-year period is designed to allay any concerns over patients filling such prescriptions with the intent of selling the drugs instead of using them. By then, the medical provider would have had plenty of time to do the blood work needed to determine they are really taking the drugs instead of just taking them and disposing of them in other ways. And there would be no longer necessary to impose on them the additional burdens and costs associated with filling monthly prescriptions in person instead of doing so quarterly. Driving to the pharmacy costs money, monthly prescriptions can be more expensive than quarterly, the time spent for the trip has a cost too. We should all look to avoid imposing such burdens on patients whenever we can. The bill got voted 18-0 out of the House committee and was adopted by the House in a voice vote. It would have been on the consent calendar, except that it did have a friendly committee amendment. So I would be very happy to answer any questions and hope you can support the bill in order to, again, reduce the burden and costs for certain patients. Thank you.
Are there any questions? I've got a couple questions.
Yes.
So this line 16 through 19 after the semicolon that discussed about getting the 92-day supply, provided that a prescription includes a statement by the prescriber that the medication is to treat chronic low testosterone, and the patient has previously filled 12 prescriptions from the same medical practice for a monthly supply of the medication. You explained the purpose behind that.
Yes.
That's a rather unorthodox approach to prescribing, and I was just wondering, is it the intention of the legislation for that to be the responsibility of the physician or the pharmacy?
Correct. Basically, that was a compromise made during that bipartisan discussion before the bill was filed, because again, concerns were that if we go quarterly from the beginning, that may allow bad actors to take advantage of this. The intent of this, and this is where the language clarified by the committee was, the intent was to clarify that the burden for that particular language is on the medical provider, because the committee felt that they were the ones who have the access to the blood work, and they are the ones who can attest to the fact that the patient is a legitimate patient. So we understand also that this is something that regulates the pharmacy, so the language was carefully written to not require the medical service providers to do anything. It merely says that if they do this, then the pharmacist has the freedom to provide a 92-day prescription. So we try to write it in the most, in the least burdensome manner possible on everybody involved.
So is the pharmacy obligated to check with the medical provider?
The intent of the language is to make sure there is no need to do that, because the prescription itself would be required to already include the language. So this should not create an additional burden on the pharmacy or an obligation to do anything. That language would have to be already on the written prescription.
So the obligation is on the provider.
Frankly, the obligation is on the patient to advocate with their medical provider to ask for that language once they're eligible. But between the two people that we may regulate, yes, the burden would be on the provider.
And I appreciate that, but that's not the way it works. I mean, when you get to the pharmacy, I'm going to tell you what's going to happen. You get a prescription for a 92-day supply of injectable medication. And I know pharmacists, they're going to be like, oh my goodness, is this my responsibility to check now the doctor? Or can I assume the doctor complied because they wrote the prescription? So I know that, so the reason I ask is, I think that all that after the semicolon on line 16,
Yes.
personally, I think that causes confusion. And personally, I don't necessarily think that's required. That's my personal interpretation.
I
And I understand this was a compromise, but I don't think you need to do that.
As somebody whose original intent was to just have a quarterly prescription from the first moment,
Yeah.
I would in no way oppose any attempts by
Okay.
the Senate to, go in that direction. But again,
Just want to make sure we were clear on that, because that I looked at ways that we could make, because I understand the objective of the bill, and I get it 100%. And I actually, quite frankly, I'll go on record saying the 34-day supply that we have is archaic and goes back decades, and we have technology that can monitor this far better than what we did when we did that. So I kind of look at that. I say I know how this goes. You know, one group is going to be pointing at the other group saying, this is your responsibility to provide this information, and the other group is going to be saying, you just do it and take. So if we could take that out, I think that would achieve what you wanted to do and get rid of any confusion. Personally,
Thank you. Frankly, it would achieve what I originally wanted to do, and I was trying to take more of an incrementalist approach to allay those concerns that were expressed to me during the process. But if this, if you feel that the bill would be better without that language, I would be very happy to support it without that language, or with that language, or in any way, shape, or form it comes out.
I think it's time maybe we look at that 34-day supply part. And we go to line 3 and have that debate, and then we're not doing this every year saying, well, we want this drug, and we want that drug, and we want this drug. That's just my thought.
I would, that is more of a bite than I wanted to take, but as I said, any version of this bill that comes out of here, I would be very
Sure.
happy to support. I know that you have a lot of expertise here on this, and I will trust your judgment on it.
Great. Thank you. Any questions from the committee? And I apologize to the committee for monopolizing your time, but. That's your day. Did you have a question? Okay. Thank you very much. We'll let
Thank
you
you.
get back to your work today.
Thank you, I will.
All right.
Page 16, Dan?
Yeah, that's what I'm thinking. All right, Representative Nagel.
Thank you, Mr. Chairman. And just to, again, I guess to introduce myself, I'm David Nagel. I'm a rep and a physician, and thank you for your line of questioning, because that just made my life way easier. As you know, you and I work together. I'm sorry to be talking to Senator Rochford directly, Mr. Chairman, but you and I served together on an ad hoc committee where we talked about issues like this and how do we improve people's ability to access controlled opioids, or other, at that time it was opioids, in a manner that wouldn't be so functionally significant, that would improve communication between the pharmacist and the doctor, so we wouldn't have to do what you just said and make life easier for both of us. So the reason why I agreed to sign on to this bill was it basically does what we wanted to do with opioid prescribing, is that my job is to provide care for somebody at the least possible intrusion on their life, their quality of life, their function, and things like that. And we need to see somebody every couple of weeks, every couple of months, until they've established that they're a patient that I can trust. And then at some point, we start to wean that, so they don't need to see me as frequently and things like that. And that makes their quality of life better, allows them to be much more functional, doesn't need to take them out of work, so they need to come up and pick up a prescription, things like that. When Representative had put that language in here, it greatly improved the bill that he had given us last year, and I thought that was a great idea, and that's why I agreed to support it. And I really appreciate the questions and comments you just gave, because I think that made things much better.
Well, if I may, I think that we could make that argument about non-controlled drugs too. You look at baclofen, gabapentin, all potentially drugs of abuse. I imagine if we put those every month, I mean, it just is going to be
It's
a
insanity.
nightmare. And going back to what I originally said, I think that 34-day supply, which has been in statute as long as I've been practicing, you look at where we were in the 90s, and I don't know when that was put in, before that, because and now we have prescription drug monitoring. We have PBMs that are monitoring that. There's electronic medical records on your end of things. I think that maybe that was a safety net at one point, but now we have other safety nets that would allow us to make it easier for patient access for these drugs. And maybe it's time we look at that 34-day supply.
Sounds like a job for the two of us to do over the summer.
Well, that's, maybe we will, maybe we will.
Volunteered on that.
I know. I should have stayed home.
Yeah. You said it. I agree.
But, you know, I think you can see where some of this stuff is, you know, it may be better to take a more holistic approach rather than, like, we had an epinephrine bill earlier this morning,
Yep.
which added just epinephrine nasal spray. But we know that epinephrine is now, there's pipeline drugs that would be other delivery systems. Rather than pigeonholing every single one, maybe we look at a more comprehensive way and we
That's
get
awesome.
a more therapeutic class or utilizing technology or a number of ways forward.
I think that's a great idea, and I'm glad I testified. Thank you.
All right. Any other questions for Dr. Nagel, Representative? All right, we'll let you both get back to work. There anyone else that would like to testify on House Bill 126? I'm going to close the hearing. I'm going to open the hearing on House Bill 370, reestablishing the commission to study the delivery of behavioral crisis services to individuals with mental illness with an impairment primarily due to intellectual disability. With that, I'll ask Representative Bernardi to introduce his bill. Thank you.
Thank you, Chairman and Committee. Representative J.D. Bernardi, Rockingham 36, Hampton Falls, Kensington, Southampton, Newton, and Plastow. HB 370 reestablishes a commission to study the delivery of behavioral crisis services to individuals with a mental illness whose impairment is primarily due to an intellectual disability. This issue really comes from the definition of mental illness found in our current statutes. And it specifically says it, meaning mental illness, does not include impairment primarily caused by epilepsy, intellectual disability, continuous or non-continuous periods of intoxication caused by substances such as alcohol and drugs, or dependence upon or addiction to substances such as alcohol and drugs. So about every year we have approximately 10 cases of individuals who experience significant enough behavioral crisis that they're brought to a local hospital. And those hospitals, which is most of our hospitals, are without appropriate staff and services for these episodes. They essentially warehouse the individuals without treatment for about 3 to 4 weeks before releasing them. There was testimony in this bill last session, both pro and con, to change the definition of mental illness as a solution for this problem, which would reestablish priorities within the system. But after passing that bill in the House, came to the Senate ultimately proposed addressing the problem by creating a commission to study it and come up with an appropriate solution. The House concurred, the governor signed, the commission was established. Okay, the purpose of the commission was to identify the appropriate procedures within the mental health services framework to ensure individuals experiencing a behavioral crisis and whose primary impairment is intellectual disability receive adequate and timely treatment. The problem was the appointment of the commission members by the governor was considerably delayed. Some members were never appointed. So the initial meeting was called in mid-October, far too late for the commission to come up with any kind of solution for proper legislation. I was serving as chair of one single meeting where we said the best thing to do is resubmit this bill and get the commission reestablished. So that is the purpose of the bill, and I'm happy to address any questions you may have. I did not muster all the people that testified on this pro and con last session. I thought that issue has been resolved. You folks made the decision. You like the commission. I thought you'd reestablish it to really get the job done.
All right, thank you. Are there any questions? Seeing none, we'll let you get back to work upstairs. Thank you. I have a motion. Oh, yeah, we're going to close the hearing on, are there anyone else who'd like to speak on 370? Close the hearing on 370.
Move into exec. Motion to move into exec.
Oh, second.
All in favor, say aye.
Aye.
Move
So-
out to pass on HB 370.
I'll second that. Any further discussion on HB 370? All those in favor, say aye.
Aye.
I'll move consent.
Second.
All those in favor for consent, say aye. Opposed? No opposition. And Senator Birdsell will take it out. And do I have a motion to leave executive session?
You want to do the other ones?
No. We'll work on a couple of those
You
anyway.
want to do that? Okay, so
Yeah.
moved.
So we'll go in a second.
Second.
All those in favor say aye.
Aye.
Opposed? None. We're out of executive session.
Count to 10.
Count to 10. No, just to let.
I can't hear you.
Microphone. No,
We have not, we're still, we're in regular, we're not in executive session. We have not adjourned for the day. I counted to 10.
Yeah.
The only question I had about it, because I think we heard this a couple of years ago, and there was concerns about harm reduction. And I think they might have answered the question that there was no definition a few years ago. There is now.
Yes.
So
If we want to go into executive session, I can give you that.
I'm okay with it.
all right, move,
All right.
move exec.
Senator Birdsell moves exec.
Second.
Oh. Senator Birdsell moved to go into exec.
Second.
Senator Abart seconds. All those in favor say aye.
Aye.
Any opposed?
Motion to out to pass on 73.
Second.
All right, we have a motion and a second. And then to answer your question about that definition of harm reduction, that's, I spoke last year with Representative Edwards on that. And that's where he crafted this definition that satisfies all those questions and concerns.
I like the idea that he added the societal piece of it, which will cover some of the areas that towns and cities that may have.
Yeah, and I remember last year when this, I was in the other body, this came up and the question arose that harm reduction was very broad. It could have meant almost anything depending on the interpretation. And this definition, I mean, he worked on it, as he said, over the summer. Senator Waters worked on it as well, Representative Nagel, and that's where this came from as a result of that broad, open-ended initial definition. So any further discussion? So the motion is on to pass on House Bill 73. All those in favor say aye.
Aye.
Opposed?
Consent.
Motion for consent.
Second.
Senator Birdsell seconds that. All those in favor say aye.
Aye.
Opposed? We'll let Senator Long take that one out. Yes.
All right,
So motion to come out of executive
So moved.
session, second.
second.
All those in favor say aye.
Aye.
Opposed? So we're out of executive session and we will adjourn for the day.
Okay.
We have gunshot on that.
Well, I've been gunshot.